This is kind of the fun part of my job. I very much enjoy deep brain stimulation and being able to really make a difference in doing the more advanced stuff in Parkinson's. Right now you've heard a lot about medications and exercise, and now we're headed into the surgical stuff. Depending on how long you have Parkinson's, you'll probably hear about deep brain stimulation. Overview, really quick. What is deep brain stimulation? When to consider it, the workup, the surgery, the programming, devices, and the future. What I want you to know is this is not new science. So taking a step back in history, if you look at this chart, 1939 is when this stuff started. So we started figuring this stuff out in the 30s. The first DBS was actually placed in 1987. Our FDA approval for essential tremor in DBS was in 1997. And in 2002 is when it was FDA approved for Parkinson's. So I hear a lot in my clinic, oh, that's scary, it's new. It is not new. This stuff has been around for over 30 years. And again, the research in it has been around a lot longer. So I wanted to touch base. I know somebody brought this up, so I wanted to touch base. There are procedures out there. Taking a step back in history again. So the story goes, how we figured out where tremor was inside the brain was that a neurosurgeon was doing surgery on somebody that had tremor, but doing it for another reason, accidentally injured or burned an area of the brain he wasn't supposed to touch, woke the patient up to explain, and their tremor was gone. And that spawned the thalamotomies. So this is what Michael J. Fox had. Then they decided, well, we don't need to do brain surgery. We can use procedures. So we can use things like Gamma knife. Gamma knife is a laser. It is not a knife. And basically, we are burning the area of the brain that's causing tremor with a laser. And you're, again, no surgery, nothing. You're just kind of sitting there. And that's how they do it. The issue with Gamma knife is it's one side, one time. So, and it's predominantly for your tremor. So, and they found over time that if you do both sides of the brain, you can cause serious damage. And if you repeat it, you can cause serious damage. So in other countries that don't have the technology of deep brain stimulation, they will repeat Gamma knife, but again, your side effects go way up as you repeat it. To touch base on the high frequency ultrasound, the high frequency ultrasound is the latest FDA approved procedure for Parkinson's and essential tremor. So it's tremor treatment. This one, and something I didn't say on Gamma knife takes up to 6 months to take effect. So you go home, still have tremor, and up to 6 months later is when you're starting to see the final result. With high frequency ultrasound, again, this is kind of going back to Gamma knife, same idea, except we're using ultrasound waves to burn the area of the brain that's causing tremor. So you go into this machine, and you're using an ultrasound wave. And you get to, in the machine, you watch your tremor disappear. It's amazing. Now, the downside of this is how long does it last? Their 5-year data suggests that at 5 years, 75% of the tremor is still gone. But as we all know, tremors progress. So again, how long does this last? And that's all research that has not been done yet, and it is still being done. The other issue with the high frequency ultrasound is, side effects. So how many side effects versus its risk and benefit? If you guys are one of my patients, you'll hear me say this all the time, risk and benefit. So how risky is it to repeat the ultrasound versus DBS? One thing I want to make very clear with DBS is it is not, DBS is FDA approved. DBS is not FDA approved after ultrasound. So if you have the ultrasound, in general, you do not get to have a deep brain stimulator after the ultrasound. So it's kind of you choose one or the other. There have been rare exceptions. I'm aware of 2 cases in actually the world that have been able to get DBS after ultrasound. But please be aware of that. So some people will say, oh, least invasive first. It doesn't work that way because the DBS, we don't know how it will work after the ultrasound. So moving on to the meat of this talk, deep brain stimulation. What is it? So these are electrodes that we place inside your brain. And for the moment, there's a battery that goes inside the chest. It's all connected. And what we do is, you can see here, this thing here is the electrode. So these are little tiny things that we'll put inside your brain. It is brain surgery, yes. So forgive me for getting a little gross. We do drill holes inside your skull. We put the electrodes inside your brain. We run a wire down your neck into your chest where this battery pack is. All this is internalized. There are 3 main areas of the brain, and I'll show it to you in a minute, where we go for Parkinson's and essential tremor. Here is, again, these are very, very tiny. Conditions treated. There are many, but this is a movement disorder conference. So conditions treated in movement disorder, essential tremor, Parkinson's, and dystonia. Dystonia does not have an FDA approval, that's why I have that on there. It's considered humanitarian exemption, easily done with the FDA. So there are 3 main nuclei that we use. The subthalamic nuclei right here. Again, these are very tiny inside your brain. And then we use the globus pallidus interna and the thalamus. These are the areas of the brain that we'll go after, and depending on your symptoms, we'll discuss it with you, but depending on your symptoms, that's what we target. The STN tends to handle tremor better than anything else. The GPI tends to handle dyskinesia better than anything else. And then the thalamus handles major tremor. When to consider DBS? When the benefit outweighs the risk. If you are newly diagnosed and you're taking your medication 1 tab 4 times a day or 3 times a day, I will not do DBS in you. And it's simply because brain surgery versus taking a medication 3 times a day, the risk and the benefit don't match up. DBS can be life-changing if you have the right surgeon, the right programmer, and you are the right patient. Those are the big things. You need to make sure that you have the right surgeon. You need to make sure you have the right programmer, that's the neurologist, and I'll explain that in a bit, and you are the right patient. When to consider DBS? I threw this in just because we do it a lot for essential tremor and dystonia. When movement is refractory to medication. So with these guys, if their tremor is so bad and we can't handle, or their dystonia is so bad and we're not able to handle it with the medication, that's when we consider DBS. For Parkinson's, it's a lot more complicated than that. Because Parkinson's is a whole body disorder, there's a lot more to consider. So is it tremor that you're going after? Is it slowness? Is it you're taking so much medication? Is it that you can't take the meds? What is going on? Your tremor dominant Parkinson's, I tend to go after these are your really big tremors. I tend to do DBS a little bit earlier in them because medications don't necessarily touch the tremor. So that's where oftentimes I'll start talking about this a lot sooner. My akinetic rigid Parkinson's, so these are the guys that are stiff and slow, no tremor. I tend to wait a little bit for them. For mixed Parkinson's, so the normal Parkinson's, you have a bit of a tremor and you have slowness and rigidity, DBS is a good tool. PD with dyskinesia. Interestingly, DBS can handle dyskinesia 2 ways. Number 1, we can reduce your medication a lot using deep brain stimulation, so that can stop the dyskinesia. So definition, dyskinesia, like Michael J. Fox, all those dance-like movements, that is a side effect of the medication, that is not the disease. So be aware, that is a side effect of dopamine. And so we can reduce your dyskinesia by reducing your medication, or we reduce your dyskinesia by putting the DBS in the nuclei called the GPI, and that will stop the dyskinesia, allowing us to use medication. Be aware, there is Parkinson's disease, and there's hundreds of things that look like Parkinson's but are not, and these are called the atypicals. I heard earlier somebody ask about normal pressure hydrocephalus. Normal pressure hydrocephalus DBS will not affect normal pressure hydrocephalus. It cannot be used in it. It won't work. Cortical basal degeneration, progressive supranuclear palsy, cortical basal degeneration, all these other ones, the DBS won't work. Lewy body dementia, DBS won't work. So please be aware. Sometimes your doctor is saying no to DBS because of your disorder. When to consider DBS in Parkinson's? So again, going back to the medications. So this is your therapeutic on state. On is when your medications are working and you feel like they're working and your Parkinson's is gone or it's not there. The off states are when your Parkinson's is showing itself. You can feel it oftentimes. And then at the top you see that peak dose dyskinesia, so that's all the funny movements. We want you mainly to be in this region here. I do not, and this is my own personal belief, I do not believe in the stages of Parkinson's. And I don't believe in the stages of Parkinson's because you can have someone that looks like a stage 4 and to put DBS in, and then they're stage 2. I can also take somebody that's at stage 2, change their medication, they look like a stage 4. So that's where, for me, I don't believe in the stages of Parkinson's. This is a objective measure for the FDA, for our research. What I believe in is early, moderate, and advanced Parkinson's. And this is what I use in my clinic to assess when we're going after DBS. So early Parkinson's, you can see your medication, you take your meds, you're basically on the whole time. Your life really isn't disrupted. These are my early onset, early Parkinson's. This is what I don't really, you're not really advanced. You're not feeling those ons, offs. You're doing well. Then you move into moderate, where you're starting to take those medications more often throughout the day. You're having more ons, more offs. You're starting to feel that cycle of the meds. And then here's advanced Parkinson's, where you're taking the medication a lot more often. You're having dose failure, so you take the pill, it's not working. You're getting inconsistent effect from the medication. And moderate to advanced is when I start talking to people about DBS, because I can make it so that that dyskinesia, the inconsistency of the medication, goes away with the DBS. What is DBS? For Parkinson's, think of it like electronic carbidopa-levodopa. It will do for you motor-wise what the drug does for you. You still need to take it because all those non-motor symptoms that we don't talk about and you can't see on the outside, that the DBS won't touch. But the motor, it is what it will take care of. It treats tremor better than any oral medication we have. So be aware that your carbidopa-levodopa may not affect your tremor. It is there to affect the stiffness, the slowness, and the internal stuff that's going on, but it may not touch the tremor. The DBS will stop the tremor. It can treat dyskinesia directly, like I said before, using the GPI, or it can treat dyskinesia indirectly by reduction of medications. So there is a workup that goes along with this, because we need to make sure you are the right patient. So I always ask that you see a movement disorder neurologist. Those of you at Hoag, we have 4, so we have easy access. I want to make sure that you guys understand the movement disorder neurologists. We are neurologists that have extra training to treat Parkinson's and to do deep brain stimulation. And we recognize treat movement disorders. We are specifically trained to program the deep brain stimulators. It does need to be programmed. And we also maintain the device, meaning that we're able to see when the device is running down, if you need a battery change, if there's any issue going on with the device. We're the ones that are in charge of it. And so that's what I want you to be aware of, and that's why you always, if you're going for DBS, you need a movement disorder neurologist. So I put up some MRIs. This is an MRI of 2 people's brains. Anybody that's going for deep brain stimulation, they need brain imaging. And the reason why is this person over here makes a great candidate. DBS, these are electrodes inside your brain. It is electronic stimulation inside your brain. That person there looks great. This person here, this is a big fluid-filled space in their brain. Think about electricity and fluid. So if I have that big fluid-filled space there, the DBS may function inconsistently. There are other reasons why this person shouldn't have DBS, but I'm not going there today. Always, before you get a DBS, you undergo neuropsychological testing, and what that is memory testing. So along your years, normal with aging, you have normal aging, then you have mild cognitive impairment, then you could get dementia. If you are on the border of dementia, I will not put DBS in you because I will push you over into dementia. The neuropsychological testing is a great tool because it tells me how long it's going to take you to recover after the surgery. And that way I can advise you, will it take you a day? Will it take you a month? Will it take you a year to cognitively improve after the surgery? This is what is so important. For Parkinson's on-off testing here at Hoag, we have Belinda who does this. Belinda has many hats. She's amazing. So the on-off testing, you come off your medication to the clinic. We videotape you doing the funny tests that we always do. And then we give you your meds and we do that test again and we videotape it. And this gives us an objective number, how well the carbidopa-levodopa is working for you. Then I highly recommend everybody goes to a DBS education series. We have this again at Hoag, where you can learn much more. about deep brain stimulation. You can talk to people who have had it done. Again, if you're one of my patients, you always hear me say, your brain, your body, you better know what's going on, which is why education is so important. At Hoag and at most DBS centers, there is a consensus board. And what this is all the neurologists, neurosurgeons, neuropsychologists, therapists, everyone that's involved in your care. We all get together. At Hoag, it's once a month. We all get together and we watch those videotapes of you. We hear your story. And it's basically having all eyes on you to make sure that we're doing the right thing. And so sometimes, again, 4 movement disorder neurologists, 2 neurosurgeons, a bunch of physical therapists, the neuropsychologists, we're all sitting there watching your videos and making sure there's no other avenue that we haven't addressed. That is so important, and it's actually just, it's good care to have. After all this, so the consensus board says, yes, we agree, let's do the surgery. Then you meet the surgeon. There are 3 device companies, they all have representatives, and you will meet your device rep after the consensus board. And basically, the device rep is one of those people that you can also call if there's ever any issues. These companies, they are worldwide companies, so not uncommon. People want to go travel. If something is going on while you're traveling, you end up in the hospital, you need the device off, you need the device on. The companies, they can track you, they can find you, everything, so you're good. The surgery itself, I'm going to let the panel after me speak to the surgery. There is a process to the surgery and there are risks. There is a wake DBS surgery and there's a sleep DBS surgery. We offer both here at Hoag. And then you will go home with your device off, so you allow your brain to heal. First day of programming, every neurologist is a little different in how they program. I usually will wait for my patients to have about 4 weeks to let their brain heal. Again, your brain is kind of shifting and it's healing, and you have all this fluid shifting inside your brain. So again, turning on electricity while the fluid is shifting around is not the best thing. You get inconsistent responses, so that's why I wait 4 weeks. At that 4-week mark, I turn on the device. And what's interesting and what is so cool is what we do is we run electricity through each electrode. There are 4 electrodes on each lead. You get 2 leads inside your brain. And so there's those 8 electrodes. And I run electricity through each electrode. And what I'm looking for is, are you having any side effects? And I do that on purpose, so that way you have this curve. And this point here and all along, these are side effects. And then I know below is where I can program. Side effects meaning you might feel buzzing, you might feel tingling, you might feel stiffness. You could develop difficulty speaking. There are a bunch of different things that I'm actually doing on purpose, so I know where it is inside your brain, and I know where I can program. First programming is typically the longest. That first programming, you'll go home that day and feel like your brain ran a marathon, because it kind of did. And then you have regular visits until you are happy with the programming. You're happy with how you function. What's really cool about the DBS as well is you get your own remote. And so for me, I always wait until I trust you, because you are able to program yourself. And so I want to make sure that I can trust you guys and not have you guys really increase the electricity and move things around. So it truly gives a lot of freedom, which is why I like it. All right, going back again through history, Medtronic, these are all the different electrodes that we have. These are the old Medtronic leads. And you can see these dark things, these are the electrodes. And then we call that full thing the lead. Now, DBS is undergoing a revolution in that it used to be before that we could only program off those 4 electrodes. You couldn't shape the wave of electricity. And so you're kind of making circles or ovals inside the brain. And the nuclei that we're covering, they are not circles and ovals, they are different shapes. And so what happens is, this is where, if you have a friend that had DBS 20 years ago, this is where we ran into a lot of side effects. Speech changes, stiffness, things like that. Now, we have a lot more advanced technology. And that advanced technology are these little splits here. So you have these splits of electrodes here. And what that does is it allows us to shape the wave of electricity inside your brain. And I have a little bit of a picture of that in the next slide, or in a slide later. But that is what is so revolutionary, is that we're able to shape the wave of electricity, we're able to move it around inside your brain, and it makes the side effects much less than it was 20 years ago. Again, if you look at this electrode here, see how large this is compared to the rest of them? That's that electrode, so you can see how small these things actually are. How the neurologist programs, I'm going to kind of speed it because I know I have just a few minutes left. So these again are the nuclei. And it used to be before that we kind of know the symptoms that you would have if we're covering the nuclei or not. And we can kind of picture it inside our brain, what we're doing. And I'm using electricity to cover these electrodes and to make your symptoms go away. Now, we don't have to do that because we have images. I want to go over the devices. There are 3 device companies. The devices, the first one I'm going to show you is Abbott. There's Abbott, Medtronic, and Boston Scientific. Abbott, their system is quite cool in that it is remote, meaning that you can be basically anywhere and you have your device with you, you need an adjustment, you can call me up and say I need an adjustment, and I can do it. So you can be, Northern California, I'm at my office, you call up, we can adjust, so it's remote adjusting. You can see here's that remote, so that's the patient talking with the doctor down there. It is Bluetooth, it can program remotely, and it is patient-initiated contact. So again, very cool device. Boston Scientific, you have individual control. So this is kind of a picture of what I was talking about, shaping the wave of electricity. You can shape this all around this electrode, all around this lead. And again, very cool device where you can just move it all around. It's ease of use. They have a rechargeable battery that lasts over 20 years. So it's this little tiny battery that would go inside your chest. You have to charge it. Most patients charge it about 20 minutes a week. That's it. And again, lasts over 20 years. This is, again, what I was talking about. So this is say you had DBS, this would be your individual brain. These are your individual nuclei. And so I don't have to picture it inside my brain anymore. I can actually just see it on the device programmer. Medtronic. So I want to show you the difference. This is their old device, their old programmer. This is their new programmer. Pretty cool, right? Change of technology over 20 years. So theirs has brain sense. And what brain sense is it can actually sense what your brain wants. So it's basically communicating with your brain, and your brain is communicating with it. And some people have tremors, some people have slowness, some people have dyskinesia. And the device can tell the difference. And so you can go home, and it gives me a nice spreadsheet all throughout the day of what's going on. Interestingly, an interesting story, I had a patient that I was scrolling through basically his week, and I saw he was calm. All of a sudden, all the brain waves were going like this, and it went on for hours. And so I asked him what happened that day between these hours. And he had this blowout fight with his wife. He was upset during those hours, and I could actually see it on the device. So it was pretty cool. We don't keep the brain sense on all the time, so you don't have to worry, we're not monitoring you all the time. But we do that in order to get a good idea of the program, what your brain needs during that time. And then so this is the brain sense part, and then I can program it based off of that. So the future, almost done. The future is longer lasting batteries. So there are a bunch of batteries that are coming out that are much smaller, much easier to use, and they last a lot longer. Some are rechargeable, some aren't. Some people like to have it in your body. You forget about it, you can go on your day, and you don't have to charge it. Some people want to be able to charge it. Doesn't really matter. It's up to you. The other thing is brain sense and AI. So that's where this is all headed. Eventually we're going to have what we call closed loop, where it communicates with your brain, and your brain communicates with it. And we don't need the battery in the chest. We don't need any wires anywhere on the inside of you. And it just automatically changes as you change. If you think about your day, you go from stiff and slow. You might have tremor, you might have dyskinesia. Sometimes you might want to move faster, sometimes you might want to move slower. And the DBS will eventually be able to do that for you. And then AI, again, that's kind of what I'm talking about, is it's going to be able to change and sense what you want throughout the day, and then it will do it. That is it for right now. I'm going to open up for questions and then head to the panel.